Welcome back to section 14 of the Falcon Physicians Reviews for online anatomy components. Now we're going to move into the organization of the upper limb, similar to what we did with the lower limb. If you look at the upper limb, it can be divided down into segments with the glenohumeral joint, the elbow, and the wrist, dividing away the shoulder girdle, arm, forearm, and hand. If you look at the compartments, the arm has a flexor and extensor compartment. The forearm has 5 areas that you want to think about. There's the flexors with both a superficial and a deep, and there's the extensors with a superficial, deep, and an outcropping group of muscles. And then finally, the organization of the hand is that there's going to be 4 areas you want to think about. There's going to be the flexor compartment, which has the thenar, hypothenar, and a group in between, just as we saw in the foot. And then there's the extensor surface. When you think about the nerves that are innervating these areas, there's the shoulder girdle, which should bring to mind the pectoral, axillary, and subscapular nerves off of the brachial plexus. Then we're going to be getting into the arm with the musculocutaneous and the radial nerves innervating those compartments. And as we cross over into the elbow, we start thinking about the median, which is the major component of the flexor surface of the forearm, and a small component from the ulnar nerve, which is going to do a few muscles in the flexor component of the forearm. And on the extensor surface, they're all done by either radial nerve or by the deep radial nerve, which will do the large majority of the muscles. Only 2 muscles which will be done from the extensors of the forearm because they cross over into the arm itself. Then finally, as we get into the hand, we're going to have a few muscles done by the median. Those are going to be thenar in orientation, and all of the rest of the muscles in the intermediate and hypothenar areas are going to be done by the ulnar nerve, other than 2 lumbricals. As we move into the bones and joints of the upper limb, we'll remember that there was 31 in the lower limb on each side, and there are 32 bones in the upper limb on each side. Those include the clavicle and scapula, humerus, radius, ulna, and then we have 8 carpals instead of the 7 tarsals that we saw in the lower limb. We have a first row of carpals, which would be scaphoid, lunate, triquetrum, and pisiform, and a second or distal row of carpals, which would be trapezium, trapezoid, capitate, and hamate. Then we have the same thing with the 5 metacarpals and 14 phalanges that we saw also in the lower limb. Let's start with a question. You're watching a local youth soccer game, and a 16-year-old soccer player is about to shoot at net when a defender pulls him backwards. Immediately, the player cries out in pain and is rolling on the ground. By the time they walk off, you can see he's holding his arms slightly away from the side of his shoulder, and it's lost its rounded appearance. You immediately offer your assistance, suspecting what type of injury. This injury is a shoulder dislocation injury. And some of the keys that you see in this is that there's a loss of the roundedness of the deltoid, which is typical of a dislocated shoulder. Not a step deformity, which you would expect with an AC separation. Or it's a lateral change as opposed to what you would see with a sternoclavicular dislocation. The surgical neck fracture of the humerus, there'd be more support and they would not hold it away from their body, and the same thing is true with shoulder separation. They're going to hold that arm close to their body as opposed to a dislocation of the shoulder, which they'll actually hold a little bit further away. Now if we look at the joints themselves, we have the sternoclavicular joint, the coracoclavicular joint, and the glenohumeral joint. The sternoclavicular joint on the medial end is the only attachment of the upper limb to the axial skeleton. The SC joint is an incredibly stable joint. It's one of the least dislocated or fractured joints. However, if it does dislocate, it typically will dislocate posteriorly, and this is of significant clinical interest when this happens because it could compress the trachea or even some of the major blood vessels in the area. But these are by high impact traumas. The AC joint is the joint that is associated with a separated shoulder, and oftentimes you'll see a step deformity which occurs with that shoulder separation. The glenohumeral joint is a ball and socket joint, which is very poor congruity because, as is the case typically, when you trade off mobility, you give up stability. And the hip, which has great stability, has very poor mobility compared to the shoulder joint, which also has very poor stability compared to the hip joint. However, it tries to compensate for this loss of stability by adding in the rotator cuff tendons, which can be seen here as well. The sits muscles, as they are called oftentimes, the supraspinatus, infraspinatus, teres minor, and on the anterior, the subscapularis. To help with the joint, there's the glenoid labrum, which helps make it a little bit better and more congruous, but even with that, you can see that about half of the humeral head does not articulate inside the joint at any one time. Of particular clinical interest, you can see the supraspinatus tendon and the associated subdeltoid and subacromial bursas, which will oftentimes become inflamed with overuse injuries in the shoulder joint. That's the most commonly torn of the rotator cuff muscles, and we'll have more to say about that a little bit later on as well. So 1 in 5 people by the time they're 80 years old will have a rotator cuff tear, but many of those go undiagnosed. They are typically the shoulder injury that happened some time ago that they never got any help for. When we think about dislocations, the most common causes are trauma, and either some diseases or defective ligament could be the cause, like in rheumatoid arthritis, which can also cause joint dislocation because of the malformations that start to take place from the long-term inflammations that eat away the bony architecture. Dislocations of the humerus occur most frequently in the inferior, and the axillary nerve can sometimes be stretched through a dislocation. Some people are chronic dislocators, and they actually can dislocate so many times that it starts to get what's called a Tay-Sachs, which is an impression into the humeral head from the labrum, and they get labral tears as well. This can result in deficits in the deltoid and the teres minor muscles. It affects abduction, lateral rotation of the humerus as well. Nursemaid's elbow is another common dislocation, and this is when typically younger children, before their all annular ligament has formed around their radial head, those younger than 5 years old at least, and oftentimes it's from an adult or another child doing an aggressive jerk on the child's forearm, which will actually cause a radial head dislocation. The fingers are often dislocated and can occur in any of the joints, but most commonly it's the PIP joint of either the little, the ring, the middle, or the index finger. Here we can see some of the shoulder dislocation positions. You can see that the glenohumeral joint is one of the large dislocated joints, and it's often in the anterior inferior dislocation that it most commonly happens, typically from traction or from an abducting movement, which puts the inferior head in a dislocating position. So here you can see an anterior, anterior inferior, and the anterior superior, which gets trapped underneath the clavicle. In this case, you'll see a significant anterior bulge in the anterior shoulder, and remember, you'll always see that loss of the rounding or the squaring off of the shoulder because of a dislocation. There's that squared off position. Remember, since it can affect the axillary nerve and sometimes the musculocutaneous nerve, you may see numbness and paresthesias around the deltoid and the lateral side of the forearm. Here's a typical presentation of the AC separation. Oftentimes this is a fall on an outstretched hand or someone hitting the very point of the shoulder in a tackle, and the AC separation will give this step deformity as the corticoclavicular ligaments tear at the lateral end of the clavicle, and it rides up over the acromion. Oftentimes the weight of the shoulder will cause it to drop away or separate from the clavicle, and that's what gives it the squared off appearance. One of the distinguishing features in the imaging that you can see is a great gap between the acromion and the lateral edge of the clavicle. There's a disc in there that can oftentimes be dissociated as well. Most of these will heal themselves with just regular traction of the limb, so they tend not to sling these and do too much to them anymore. And if they won't heal completely properly, they'll oftentimes have a remnant of this step deformity for the rest of their days. In the clavicular fracture, there's oftentimes more displacement. Clavicular fractures occur most frequently at the middle and lateral thirds of the clavicle, and that's because it's a bare spot and there's no area of muscle to dissipate forces when they're transferred up through the humerus into the clavicle. This is a breaking out point. In this case, the patients will typically support the sagging limb close to the body with the opposite hand, and you'll get a dissociation of the proximal and distal components of the clavicle. Sometimes subclavian vessels can be at risk, or the brachial plexus can be at risk because they lie directly behind the clavicle and the subclavius muscle. Sometimes the supraclavicular nerves will be trapped in the healing bone. The supraclavicular nerves are coming down from the cervical plexus and distributing over top in a medial, intermediate, and lateral branch that we'll discuss in head and neck, and that callus formation can entrap them, causing an irritating chronic neck pain that has fairly little significance clinically other than it's annoying. Tubercles of the humerus and this proximal end of the humerus are where the rotator cuff muscles will attach. We have a greater tuberosity and a lesser tuberosity, which create an intertubercular groove in between, and there's three muscles that you want to be aware of that attach in there. Those are where your sits muscles attach: supraspinatus, infraspinatus, teres minor, more posteriorly on the greater tuberosity, and then on the lesser tuberosity, a very distinct pull from the subscapularis, a very powerful medial rotator muscle. The supraspinatus is going to be an abductor, and the IT muscles are it for lateral rotation. When we look at the intertubercular groove, or the bicipital groove, there's a floor and two lips to it. Those three muscles that attach in there are pectoralis major more laterally, latissimus dorsi in the floor, and teres major on the medial edge, all of which are powerful medial rotators. They're right around the level of the surgical neck, which is the most common site of fracture of the humerus, not to be confused with the anatomical neck, which is where the capsule of the shoulder joint will attach around, and the tendons of the rotator cuff muscles will reach just beyond that to get to the locations that we've noted earlier. On the humerus, we have the trochlea and the capitulum. Remember, in the cross-section of the distal humerus, it's triangular, whereas in the proximal section of the humerus, it's round. So if you're looking at imaging of these areas, you can tell where you are based on the cross-sectional shape of the humerus. We have an outstanding medial epicondyle and a more blunted lateral epicondyle. Notice also from the posterior view that you can't see the capitulum posteriorly. You can only see the trochlea. From an anterior view, you can see both trochlea and capitulum. And the olecranon fossa, which will accept the olecranon process of the ulna during extension of the elbow. This can actually fracture through that point, but in some, just like this one seen here, there's an actual hole within the bone, and it's not a fracture, so be careful of seeing a hole in the olecranon fossa and jumping to conclusions that they've got a fracture. The carrying angle is dictated by the trochlea's attachment to the ulna, and the carrying angle is important for hip clearance. which means that when you reset a supracondylar fracture or an elbow dislocation, you have to make sure that you account for that hip angle or the carrying angle, which will be greater in women and smaller in men, usually 10 to 12 degrees in men and 12 to 15 or 16 degrees in women, simply because they have a wider hip angle. Don't forget about the ulnar tunnel or the cubital tunnel, which will be right around the medial epicondyle, and this is where people will hit this nerve as it's exposed there at the medial epicondyle, and it's called the funny bone. It's not really funny, but it is the humerus. As we look here, the angle between the trochlea, that sets up your carrying angle. Forearm bones and joints. We have 3 joints associated with the forearm itself. There's a proximal radioulnar joint, which is synovial. There's a distal radioulnar joint, which is synovial. And then we have the interosseous membranous joint in between. All of which are important because it's the radius that articulates with the wrist, but it's the ulna that articulates with the elbow. So the forces that are dissipated from the hand into the wrist and then up to the arm and the elbow have to be transferred from that lateral radius into the medial ulna. The radiocarpal joint is the distal component of that, and the radiocarpal joint is really an articulation between the scaphoid and the lunate bones along with the radius. And then there's a small disc at the distal end of the ulna, which really doesn't play much of a role other than force dissipation at the wrist itself. The big component of moving the forces across are actually going to be because of the line of weight. So a fall on the hand will transmit forces through the base of the radius, which will then transmit along this line of weight across the interosseous and into the proximal end of the ulna. That's why you tend to see distal fractures of the radius and sometimes more proximal fractures of the ulna. And that's the line of weight that it's carrying the forces through. Not to be confused with the line of weight, there's a line of rotation. And this line of rotation is where the actions of supination and pronation occur. So you can see that the axis of rotation for supination is right through the radial head proximally and right through the ulnar head distally. And which is why it's really called the radius, because it circumscribes an arc, a hemisected circle, around the head of the ulna, which would be called a radius. As we look in the hand, we can see in this picture the carpal bones with the metacarpals distal to that, and the 14 phalanges that we've discussed distal to that. Remember, just like the big toe, there's only 2 on the pollex or thumb, and there's 3 with each finger or digit. We have intercarpal joints in black, metacarpal joints in blue, and then we have metacarpal phalangeal joints in red, interphalangeal joint at the thumb, and we have proximal and distal interphalangeal joints at each finger. So a myriad of different joints. They're numbered in the hand, similar to the foot except the opposite direction. They're numbered from the thumb across to the 5th digit, 1 through 5. Let's remind yourselves of the carpal bones, and there's the scaphoid, lunate, triquetrium, and pisiform bone in the proximal row. And then there's the distal row from lateral to medial, which would be trapezium, trapezoid, capitate, and hamate. One way that I use to remember these is using the mnemonic that some lovers try positions that they can't handle. Notice how I spelled try with the T-R-I to remind myself of the triquetrium bone. Also, the pisiform bone is a sesamoid that's encased within the tendon of the flexor carpi ulnaris tendon, and that there's 2 more T's in the distal row, so that can become confusing as well. I could not remember which one was which, and the way that I remember which one is with the thumb is that the trapezium is with the thumb, and that's the only saddle joint in the entire body. and that puts the movements of the thumb at 90 degrees to the exact same movements of the fingers. So if you look carefully, you can see this peanut-shaped scaphoid, which is directly across from the lunate bone. The lunate is the most dislocated bone in the wrist, and the scaphoid is the most fractured bone in the wrist. So those are two clinically important things for USMLE. You'll typically see those tested regularly. Another important factor is to notice that bone 7, the capitate, actually comes down across the middle of the scaphoid bone, and that's the one that comes down on a fall on an outstretched hand and will sever it across that waist of the peanut that you can see in the scaphoid, causing the fracture. A little bit more on that later. If we look at scapular fractures, you can see by following the lines of this axillary view that there is a significant gap along the lateral edge of the scapula. This is not a common fracture, but when you do see it, expect it to be with high impact blunt force injuries. So this is going to be the skateboarder, the snowboarder, or someone that's whacked with a baseball bat. They're oftentimes accompanied by thoracic trauma, so they can get missed in many cases because they're so focused on the thoracic trauma that the scapular fracture is secondary to it. And it's simply because of the placement of the scapula that it's so close and that it doesn't get injured without a high impact force that these are two things tied together commonly. What's going to happen is you're going to have difficulty with scapulothoracic movements, which is going to include abduction and flexion or circumduction, especially as they get past 90 degrees, or any of the muscles that are pulling off that lateral border and trying to displace that fracture. Definitely you're going to see local tenderness, pain, and a significant amount of swelling. On that medial border, remember there's a significantly sized vessel at the site of this fracture that could be damaged, causing vascular bleeding into the area as well. When we look at humeral fractures, there's several things that we want to tie in together, and we're going to take some time on this because there's a lot of nerves that are associated with fractures at these areas as well. We've got the fracture of the surgical neck should automatically get you thinking about the axillary nerve and its potential damage. Then if you have a fracture of the midshaft, you should think about whether it's above the deltoid tuberosity or below the deltoid tuberosity. Those that are above the deltoid tuberosity have the opportunity to knock out the triceps. Those that are below the deltoid tuberosity typically do not knock out the triceps, but they will knock out everything below the fracture if the radial nerve is involved. So fractures of the shaft, think radial nerve. When you get into the supracondylar fractures, the most common one to be damaged is going to be the median nerve as it crosses anteriorly in front of that fracture, and the fracture is going to be displaced anteriorly and can pinch that nerve. So median nerve with supracondylar fractures. If you go towards the medial epicondyle and get an avulsion fracture from the common flexor tendons or from an impact to that specific and exposed area of bone, you want to think about the nerve that's passing right behind that medial epicondyle, and that's going to be the ulnar nerve. We'll be coming back to some of these nerve injuries and what that means as far as loss of mobility a little bit later on. So if we look at surgical neck fractures, that's one of the most common fracture sites of the proximal humerus, and has a high incidence of avascular necrosis with anatomical fractures, but there's going to be more common fracture of that humeral head, which can be pinned. The upper fragment of the surgical neck fracture is going to be abducted and externally rotated by the muscles inserting onto the greater tubercle because of the infraspinatus and teres minor muscles, while the lower fragment with that intertubercular groove, the pectoralis major, latissimus dorsi, and teres major, are all powerful medial rotators, so that portion ends up getting adducted and internally or medially rotated. In a mid fracture or midshaft fracture, they're going to have damage to the radial nerve and oftentimes the profunda brachii artery, which is in that spiral groove. And the pectoralis major muscle is going to be adducting the proximal fragment, whereas the deltoid muscle is going to be pulling that distal fragment towards the proximal end. So with these kind of fractures, the distal to the deltoid insertion, the deltoid is going to abduct that component of the proximal fragment, and then the biceps is going to pull the distal fragment proximally. The avulsion fractures at the medial epicondyle are going to be forceful abduction in an extended elbow. They're often more common in children, especially that ulnar collateral ligament is going to be involved, is so strong that it oftentimes just pulls an avulsed piece off. And that fragment will get pulled distally from the common flexors that attach there, and you'll tend to get the same kind of numbness that you would get when you whack your funny bone. You're going to have medial 1.5 digits loss of sensation. You may also have loss of motor stuff that we'll discuss a little bit later once we've gone through the brachial plexus. In the supracondylar fractures, here you can see a grade 3 supracondylar fracture. Notice how that anterior displacement occurs with the proximal end, and you get the distal end being pulled posteriorly because of the attachment of the triceps. The brachial artery can be compromised by this type of fracture, and it can actually cause a compartment syndrome, and oftentimes the Volkmann's ischemic contractures can occur as a result after the healing of these types of injuries. The anterior displacement of that jagged bone is going to also put the median nerve at risk, and the bleeding into the area has the potential to have a post-traumatic myositis ossificans, which is going to cause the blood in the area to be irritated by the periosteal cells, which can actually cause ossification of that bony spicule. Here you can see a myositis ossificans in the bicep, and there's a spike of bone buried inside the biceps muscle. Sometimes they're asymptomatic, but other times these can actually be irritating upon function of the muscle, especially in the large muscle groups where they can be quite large and irritating, such as the quadriceps or the biceps. They typically will be a result of a significant trauma, oftentimes like a big hematoma, being kicked by a horse or hit by a bat, something blunt, which causes bleeding right to the bone, like a big Charlie horse. Many of them are harmless, but as I said earlier, depending on where they are, they can compress bone, they can encase around nerves, and cause entrapments. Fractures. This is going to involve supination and pronation, so it's a little bit of a complicated thing. I think you need to spend a little bit of time thinking through what happens to the proximal and distal bones. And here, rather than the deltoid tuberosity as in the humerus, you want to think about the bicipital tuberosity. The bicipital tuberosity is the separation point between the supinators and the pronators. All of the supinators are going to be proximal to that bicipital tuberosity, or at it itself, and the pronators are going to be distal to it. So if there's a fracture in between those two, a proximal fracture to the pronator teres, there's going to be supination of the proximal component and pronation of the distal component. If you have a fracture distal to that, most of the supination is still balanced out by the pronator teres, and it essentially presents itself in a anatomical view. However, if somebody was trying to pronate or supinate this broken bone, there'd be significant pain. And olecranon bursitis is, again, something that can be caused by overuse as a friction against the desk of a student that's studying constantly and has their hand or head or elbow rubbing against the table. And what can happen a lot of times is it will start to look like there's a golf ball stuck under your skin if you get an olecranon bursitis. They can also be from trauma, if somebody falls off a bicycle or a motorcycle and impacts the sidewalk with their elbow. Hockey players can do this if they're not wearing elbow pads. It will swell up like a golf ball's under their skin as well. The significant part of this is if they get a secondary injury, that fluid can drain from the burst bursa and cause a compartment syndrome on the forearm. Here we see a boxer's fracture, or a not-so-good boxer's fracture, where we have metacarpal fractures from people hitting things. And typically, if a real boxer hits something, they tend to strike things with their second and third digits, and they'll fracture those metacarpals, whereas somebody that's not a skilled fighter or gets unlucky and hits the lateral side of their hand will oftentimes break their fourth and fifth metacarpals, as seen in this picture here with the fifth fracture. Let's do a question and think about fractures. Following a cycling accident in which a 28-year-old woman fell on her outstretched hand, she noticed a pain in her anatomical snuff box. Radiography indicated a fracture. The orthopedist pinned the bone fragments together. Which bone was most likely involved? As soon as you see that anatomical snuff box, that should be a red flag for you. Fall on outstretched hand, the age of this individual, all will be important indicators for the fact that she's probably got a scaphoid fracture. Remember, the lunate is an option, but it's more often a dislocated lunate at this point. And the capitate can be fractured, but again, not near as often as the scaphoid, and the ruling out feature there would be that it's not in the snuff box. If you were to ask this person for a follow-up visit with an x-ray a week later, why is it likely a concern that you would order this follow-up? Well, in this particular case, the fall on an outstretched hand or fouche injuries oftentimes have deleterious effects that need close monitoring because of an avascular necrosis that can happen to the scaphoid bone. So let's think about what happens as these fall on outstretched hand injury or fouche injuries are gender and age specific. So if you're 10 to 4 years old, you oftentimes will have a torus fracture, which is similar to a buccal fracture. And they oftentimes stay at the distal radial metaphysis. If you're 11 to 16 years old, you're increasing your chances of having a type 2 Salter-Harris fracture, which is at the epiphyseal plate. And if you're 17 to 40 years old, you're more likely to be in the category where you'll have a scaphoid fracture. Once you get beyond 40 years old, now you're looking at the Colles fractures, which is going to be a silver fork deformity, also known as. Let's look at a few of these now. Here you can see the torus fracture, and you can notice the splintering effect that happens with these buccal fractures in soft bone of children who are very young and bouncy. And notice how they're quite hard to pick up sometimes because of the rebound that occurs in these fractures. You can see a second one that's often to the ulna on the other side. Looking at the Salter-Harris fractures, there's several different types, but type 2 is one that's susceptible from falls on outstretched hands. And in this thumb, you can see how there's been a fracture through the growth plate. And oftentimes these will create problems for kids between the age of 11 to 16 years old. Once we get to 17 and 40, we're back to our scaphoid fracture. Here you can see the outline of the scaphoid bone. And then you can see how the distal blood supply comes into the distal portion of that bone and then supplies the proximal bone. So when a scaphoid waist fracture occurs through the capitate hammering down on that waist, it will oftentimes dislodge the blood supply to the proximal portion, which can lead into a necrosis, as you can see here, taken a couple weeks later. So oftentimes you'll need to have a follow-up to make sure that that is juxtaposed well enough that it's not creating a lucency in that fracture site. The Colles fracture, over the age of 40 at this point. and the Colles fracture is going to have basically a crushing and fall on an outstretched hand for someone over 40, and it's going to cause a silver fork deformity by driving the distal end of the radius backwards or posteriorly. If they fall on their outstretched hand and it buckles them forward, that would be a similar fracture, but it would go anteriorly, and then it's called a Smith fracture. Here you can see that distal portion on each of the lateral and AP views of this person's film. That concludes our section on the organization and bones and some of the relevant fractures of the upper limb. Our next section will deal with the vessels of the upper limb. That concludes